Welcome to the SWOG Survivorship Committee meeting. Hopefully you are all enjoying your day from the comforts of your home or office. Sadly, we are not together in Chicago, but hopefully we'll be together in April in Seattle. It's not in San Francisco this spring, it's in Seattle. So we have a wonderful session planned this morning. And Hallie, should we have any opening comments about the agenda before we introduce our speaker?
No, I think we're just going to have a speaker, then we will move right into the updates on protocols, followed by the updates from our liaison and cardiac advisory committee.
Okay, great. So I have the pleasure of introducing our guest speaker today. Dr. Eric Zhao is a psychologist at Dana-Farber Cancer Institute and on the faculty in the Division of Sleep Medicine and an assistant professor at Harvard Medical School. He studies how we can better understand and treat sleep disorders in both pediatric and adult populations with a focus on cancer survivors. His work's been funded by the National Cancer Institute, PCORI, private foundations, and the pharmaceutical industry. He's published more than 60 manuscripts in the field of behavioral medicine, and he serves on the editorial boards of Annals of Behavioral Medicine and the International Journal of Behavioral Medicine. We thought this was a very timely and important topic, and I was fortunate to hear Eric give a talk a couple of years ago, and it was a fantastic presentation on sleep. So you can use the chat function to make any comments or ask any questions, and Hallie and I will field those questions to Dr. Zhao after his presentation. So I will turn it over to you, Eric. Thank you very much for being here today.
Thank you kindly, Dr. Moore, Dr. Irwin. Appreciate the opportunity to chat with the group about sleep. As you see in the title of my presentation, Changing the Standard of Care for Insomnia in Cancer Survivors, my hope is that by the end of maybe about 45 minutes or so, I have compelled you to at least think about how insomnia is managed at your institution and perhaps open that conversation about how we can do this a little bit better. So in terms of our disclosures, there are a couple that are listed here on this slide and none of which affect the content of my talk today. Now, in this question of why this should matter, why sleep should be an issue for SWOG members, as part of your mission and values, you prioritize patients and best science. This is something that is understandable, makes sense, and of course, something to think about. In terms of what matters to patients, sleep is a massive problem. So this past year in breast, there was a study that was done out in Finland where they looked at long-term health-related quality of life among breast cancer survivors. And what they did was they looked at 300 and some survivors across the lifespan and compared them to almost 900 age-matched controls. Now, this is, of course, something that is interesting to think about. We wonder, well, what really mattered to them? They looked at a whole host of different quality of life domains, from vision to speech to vitality, et cetera. And if you look at this particular table, I know it's a bit of a convoluted one, but the lines that go across left to right are compared to the age-matched norms. Anything below that is indicative of worse functioning for the breast cancer survivors. And what we actually see is that sleep takes the #1 prize, the big winner for the biggest problem over time relative to an age-matched control group, which is not surprising, I'm sure, as you're talking about and thinking about your patients, but really nice to see in the data. Now, I'm going to transition from sleep in general, in terms of problems with sleep, to this idea of insomnia disorder. It is a specific disorder that describes difficulty with falling asleep or maintaining sleep for at least 3 months or more. And that bar, I hope that you think, is actually not that big of a bar to reach. Now, in terms of insomnia, we know that in the general population, a little less than 10% are likely to be diagnosed, or diagnosable, I should say, with insomnia. Among cancer survivors, however, we see that over the course of the first year and a half after treatment, almost 1 in 3, over 1 in 4 for sure, are individuals struggling with insomnia. So this is prevalent. It's not something that you're not going to see in your clinic. Now, it's not viewed as a problem. In fact, if you happen to be in the Northeast in the New York areas, you can hop down the street and pick up some Insomnia Cookies, which makes it sound completely benign, something that is completely not harmful. And why in the world should we even care that somebody has insomnia, which is, of course, not really the case. Some really wonderful work was published out of Stanford a couple of years ago, where what Dr. Palish had done was she had looked at groups of women who were metastatic breast cancer patients. She had tracked their sleep using an objective device called an actigraph. And they looked at sleep efficiency, which is a really important metric for clinicians. What it is it's a ratio of the amount of time that a patient is actually sleeping divided by the amount of time that they're in bed. Of course, higher is better. 85% is usually used by clinicians as a cutoff for good versus bad sleepers. And those were the two groups that she looked at. What Dr. Palish found, if you looked at the survival curves, were that women who were good sleepers were much more likely to survive 8+ years after they started following this group, which is really powerful. In fact, the takeaway from that particular study was that their data suggests that among the poor sleepers, simply improving efficiency by 10%, and this is controlling for a whole host of medical characteristics, that would lead to a 32% increase in survival time. Now, I'm going to make an argument if Pfizer or Merck or any medication was able to improve survival for metastatic stage disease by 32%. You're talking about a company that is suddenly going to be, those executives are going to be very happy with their shares that next year. Now, in terms of how we treat this when we talk about the science, because as I come back to, SWOG cares about the best science, we actually have a pretty good idea of what that should look like. So the NCCN, as you may know, publishes survivorship care guidelines. This is the most recent version. And in their guidelines for insomnia disorder, there is a very clear suggestion for what should happen. Preferred is something called cognitive behavioral therapy for insomnia. Now, this is also agreed upon in the general adult population, as the American College of Physicians has recommended that this program, CBTI, is the first-line treatment for patients with insomnia, and that pharmacotherapy should only be used after a thoughtful discussion with patients when CBTI has failed. Not as the first thing, but when CBTI has failed, and only then. Now, that, of course, is not really what's happening in our clinics. We see in this particular study done by Samard et al. That 4 out of 10 cancer survivors are taking hypnotic medications for the purposes of sleep. And these are individuals who are taking it every now and then. Of those 4 in 10, over 50% are taking it as regular users, meaning most days of the week, and chronic users, which means they've been taking it for at least 6 months or more. So these are long-standing, consistent users of medications for their sleep. Of course, we know that there are a number of concerns associated with the use of medications for sleep, not necessarily just mortality as you're seeing here, but also the side effects, the daytime sequelae of taking a medication for sleep that are at least worrisome. And perhaps for some of the audience, we don't even think about some of the potential drug-drug interactions between medications used for sleep and those that are prescribed for treatment of our cancer patients. So for example, in this case, tamoxifen. We actually do know that for tamoxifen, a couple of drugs have been demonstrated to have some in vivo inhibition of the actual mechanism in which tamoxifen may help our patients. Some of the common ones that are used for sleep, off-label, of course, Paxil, Cymbalta, and hydroxyzine, are things that at least are worrisome to think about. Now, I also hear in clinic a lot of times, well, you know what? What about things that are over the counter? If we can buy it at CVS, it's got to be safe, right? And melatonin is probably the most common one that I hear about now. It's almost something that I consider to be vitamin M. It's viewed often by prescribers, oncologists, et cetera, as just being safe because our body physiologically produces this, and why not, right? Well, not only is there limited efficacy data demonstrating that melatonin is good for initiating or sustaining sleep for patients with insomnia, but we actually know that since it's not FDA regulated, that there are a number of concerns about the quality of the product that they're buying. We see that there's a lot of lot-to-lot variability, and importantly, because melatonin is a precursor, or serotonin is a precursor for melatonin. It's actually found in a lot of these samples. Other commonly used over-the-counter solutions for insomnia include anticholinergics, example, Benadryl. And we actually also know that taking medications such as Benadryl is also associated with an increased risk of dementia. Again, these are large population-based cohort studies, so of course we can't draw conclusions from that, but at least the evidence suggests this is something to at least think about. The biggest issue I have with all of these prescribed or over-the-counter solutions is they don't solve the problem. They mask a symptom for our patients because if they're taking, say, a zolpidem, they're potentially going to sleep that night. But as soon as you stop that zolpidem, well, they're kind of screwed. They're stuck in a position where their continued insomnia will persist, and they don't have the tools to be able to change that outcome. Now, coming back to that slide I showed you earlier of the American College of Physicians recommending CBT for insomnia, well, I should also add that the American Academy of Sleep Medicine, the Canadian Sleep Society, and the European Sleep Research Society all agree that CBTI should be what we offer our patients. Now, earlier this year, we actually published the AASM, or the American Academy of Sleep Medicine Clinical Practice Guidelines. I had the privilege of serving on that particular committee. And these are the results from the systematic analysis that was done. If you look to the right of this convoluted table, what you see is a line going down, top to bottom. Everything to the left of that line, if we're seeing where the dots land, suggests that it favors CBTI as the treatment approach. Everything to the right suggests that control should be favored. And hopefully you can see that whether we're talking about in-person delivery, group delivery, self-help delivery, internet-based delivery, telephone delivery, video delivery, across all of these modalities, CBTI works. Now, you're thinking to yourself, I imagine, well, this patient, we got to treat the thing that's really causing their insomnia. Depression tends to be a really common thing that I hear, but beyond mood disorders, I also hear about physical health issues. In terms of that particular worry, it's actually the reason why in the nosology of insomnia disorder in the DSM-5, they dropped the term primary, because we actually know that insomnia is its own disorder, whether or not this individual struggles with other health issues. And we see in the data that CBTI, for example, in psychiatric populations, works beautifully. In this case, you see that it's highly effective in this particular systematic review at improving sleep in patients with comorbid psychiatric disorders, be it depression, anxiety, PTSD, etc. We also see from study after study after study that if you're talking about physical health issues, whether it's chronic pain, arthritis, fibromyalgia, and of course, our cancer patients and survivors, this approach works, which means we don't have to wait for the pain to be treated to treat the insomnia. In fact, the argument is consistently made that you should be treating the insomnia often first because it can help improve those other comorbidities. Now, hopefully you're thinking, this sounds like the bee's knees. We should be thinking about doing this at our center. How are we actually doing? Well, about 5 years ago, I did a survey with some colleagues at the Dana-Farber to understand in adult survivorship programs. And some of you may have actually been the unwilling recipients of our request for survey completion. And I appreciate your time if you did complete it for us. We asked how well we were doing. We surveyed programs around the country that we felt were probably the best resourced and by extension, likely to be doing hopefully the best job that we can imagine, which means we surveyed sites that were both NCCN member sites, as well as being an NCI designated comprehensive cancer center. There were 20 some odd programs. This quote from one of the directors was really telling for us. They said, to be honest, this is a Pandora's box that we just aren't equipped to open. Perhaps the best summary of our data there is we asked the question, what percentage of your survivors do you think are getting what you consider to be just good, not optimal, just even good insomnia treatment? And here I highlight, not a single program thought that over half of their survivors were receiving good insomnia treatment. And a whole lot of programs thought that less than 1 in 4 of their survivors were getting good insomnia treatment. Now, this may be reflected by actually what's going on in our clinics. So along with Dr. Roykalitis, we looked at our center. And in this case, we looked within a cohort, it's a local cohort of adult survivors of childhood cancer. What happened in this study was during a medical survivorship visit, they completed a whole host of surveys, including sleep questionnaires. And then we went back to look at their medical record from that particular visit that coincided with the time and date that they filled out those surveys. Based on those surveys, we looked to see whether or not they reported clinically significant insomnia symptoms. And then we looked at their medical records to see, did their medical provider talk about sleep problems and put that in their note? Well, among patients who did not have insomnia, about 1 in 3 talked to their providers documented that they had no sleep problems. For those that did have elevated insomnia symptoms, the exact same ratio, the exact same proportion of patients talked about sleep and had that documented in their visit, which means it does not matter, at least at our site, whether or not a patient has insomnia or not, the likelihood of their provider talking to them about this and not even counseling them, just even talking to them about this issue is exactly the same, which means it's very unlikely that this is going to be something that is systematically happening in the right way. Now, let's pretend like what I just shared wasn't reality, that everyone is talking about insomnia and we're identifying it. Well, there are challenges even when insomnia is identified by our providers. These are 2 big ones. One, much of our care, especially at places like NCI comprehensive centers, they're in big cities, Boston, New York, Los Angeles, Chicago. They're not going to be in rural parts of the country where a lot of the issues might exist, but there's just really no care. Compounding that problem is the fact that there are not a lot of behavioral sleep medicine trained experts in this country, which is an issue. I'm going to highlight both of these for you. So in terms of the geographic limitations that I brought up first, we did a study of almost 300 children seen specifically for sleep disorders at a clinic out in Philadelphia. And what we saw was that they traveled an average of almost 25 miles to go and see that sleep provider because that's where the expertise is. Now, as you might imagine, higher SES and white individuals were more likely to actually travel this distance, which is a health disparity issue that I don't want to dive into, but at least I want to highlight here. Now, this number may not mean something to you, 25 miles. And if we were in Chicago, this would actually mean much more to you. But 25 miles is actually about the distance if you happen to fly into O'Hare, go down to the Lurie, and then go out to Midway to catch your flight home. That whole distance is what an average family would have to do in order to get their child seen once by a behavioral sleep medicine expert, which, if you know Chicago traffic, is really not a whole lot of fun. And for a lot of families, just is not feasible. Now, a second issue that I mentioned were that there weren't enough providers. This is work that Dr. Perlis out at Penn had published a couple of years ago. And it's a heat map of sleep medicine experts that do behavioral sleep medicine or CBTI work. And it's concentrated in most of the geographic hubs that we expect them to be. And there are whole parts of the country. It's a wasteland for behavioral sleep medicine expertise. And that is a huge issue for our patients because we know not everybody lives in New York City. Now, some of the things that we've done at our program to try to address this. So first is we all think about the internet as a way and as a mechanism for delivering treatment. And we published about 1.5 years ago results from our work in adolescent and young adult cancer survivors. What we used is we built upon a program developed by Dr. Ritterben out at the University of Virginia, a program called Shutir, or Sleep Healthy Using the Internet. It's about 15 plus years of data demonstrating that Shutir is not only efficacious, but likely now to be effective in multiple patient populations. Here's a list of a bunch of trials that they had up until 2020. And every trial published suggests that this is a very good program. It delivers CBTI, I should add, I'm sorry, I forgot to mention that, to so many different people across different countries and continents, and it works. This is what the program looks like. Each of these individuals tells a thread, a narrative, a story about their insomnia that explains to the participant, well, these are my issues. These are the ways that I overcame some of these issues. And these particular individuals help people through the common challenges with implementing any sort of a behavioral intervention like CBTI. If you're looking at this program, you're probably thinking to yourself, well, if I'm an adolescent or a young adult cancer survivor, as much as I'd like to think I look like Mark, probably not going to be a 24-year-old look. So what we did was we adapted the program both visually as well as changing the didactic content to address many of the developmental and disease-specific, in this case, cancer-specific sequelae, to make this program speak to our patients at the Dana-Farber. A primary outcome was the Insomnia Severity Index, which is a widely accepted tool to assess insomnia symptomatology. At baseline, what we see, and it's cut off in terms of two different levels. 14 and above suggests you have moderate to severe symptoms. Below 7 suggests you have no insomnia, and subthreshold insomnia is in the middle. We saw that our patients, because we targeted patients with insomnia, definitively had symptoms. 8 weeks, and just so you know, the program lasts 6 sessions over 8 weeks. So 8 weeks was the post-intervention follow-up period. At that post-intervention, they were in the subthreshold phase. And then we see that 8 weeks after that, or 16 weeks after baseline, that their insomnia had essentially been successfully treated. And the reason we see these continued gains is because individuals are taught the tools. That's the beauty of CBTI. They know what to continue to do to continue to improve their sleep, as opposed to, say, if we withdraw medication at 8 weeks, we likely are to see a rebound in their insomnia symptoms. We also saw that in our participants, physical health quality of life improved over the course of the program, as well as psychosocial health. And these results are consistent with all of the other CBTI trials that measure these outcomes. We do know that we can make many things better if we continue to improve sleep. Now, I do want to emphasize a limitation of this, that we're not going to be able to address it in the course of this talk, but at least something to think about, food for thought. Our average participant was almost 20 years old. The range was 14 to 25. This was our AOA audience. As I mentioned, it was a 6-session program. We find that generally, if you completed the first 3 sessions or more, you were likely to receive a lot of the benefit from the program. It's not to say that the last couple of sessions are a waste of time, but the first 3 sessions contain the 2 most important elements of CBTI, which are sleep restriction and stimulus control. And so we really want to get people to that point. And what we saw, and these are the completion rates, by the way, in our program, that 15% of our participants only completed the first session, 10% completed sessions 1 and 2, 10% completed sessions 1, 2, and 3, and so on. So essentially, only about half of our participants got to the point where we really expect their sleep to make that turn for the better. And importantly, 1 in 10 of our patients, or participants, I should say, didn't even complete 1 full session, that they looked at the program and thought, this is not for me. That 55% number, of course, is a concern, especially when we compare it to the initial validation study of Shutir that was published by Dr. Ritterband about 10 years ago, where they had completion rates of 86%. Of course, there's a number of reasons to explain this. They were cancer survivors too, but they were much, much older. The average age was 54 rather than 20, like in our study. Now, I would love to dive into all of the issues why a 20-year-old isn't going to engage in an automated intervention. That's the subject of another grant that we're hoping to get funded, but that's something to at least think about for your AYA audience. Now, I mentioned earlier this geographic issue and the too few providers, which we had hoped to address with this internet-delivered program. Another issue is this idea that these programs are 6 one-hour sessions, often delivered over the course of 8 weeks. That's the standard for CBTI. Now, 6 times of going to the Dana-Farber is absolutely what a patient will sign up for if it's to see their oncologist. For them to go and see a psychologist to treat their sleep, as much as I'd love to believe that they're going to come hang out that often with me, it is and it presents a consistent challenge. So what we thought was, what if we did a lower dosage of this? And we trialed 3-session programs for both the AYA as well as the adult population at our institute. And you'll have to trust me, or you can certainly refer to both of these citations. We were able to demonstrate effect sizes that were comparable to standard CBTI, and we deliver these programs both remotely via telehealth as well as in group-based settings, which, if you remember a bunch of slides ago, I shared the American Academy of Sleep Medicine systematic review chart, and it showed that really delivery method doesn't change impact of the intervention. We found that just the same. But instead of those particular programs, what I want to highlight is some work that we did in stepped care. This is what I believe is something that we can replicate and do better in our centers, where you may not have somebody on staff to deliver specifically a full-blown cognitive behavioral therapy for insomnia program. In our stepped care trial, and I should say, stepped care is a principle that in mental health has been adopted all across North America. It's used in primary care and college care centers simply because we know that the need for mental health vastly outstrips availability of treatment providers. So in our program, what we thought was, all right, what are our patients already done? Well, they've gone to Dr. Google and they've gotten these healthy sleep tips, and they essentially amount to sleep hygiene. And in fact, sleep hygiene is the most commonly distributed intervention, both in our cancer centers as well as in the general community. I would bet that if any one of you had a sleep disturbance and you told your primary care doctor that you had insomnia, he or she would be very likely to either say, I'm going to prescribe you something, or I'm going to give you this handout that's talking about sleep hygiene, which means avoiding caffeine, turning off your screens, and all of that stuff. Well, the data, bad news for you, is it tells us that the wide popularity of sleep hygiene is disproportionate to the efficacy of the approach, which is essentially Ed Stepansky and James Wyatt's kind way of saying sleep hygiene is just junk. Now, the content is not junk. It's good information. You shouldn't be drinking coffee at 11 p.m. and expecting to fall asleep at 11:15. But it's often the delivery of that particular suggestion. It's like an overweight patient being handed a tip sheet on how to eat healthy, and that primary care doctor expecting that patient to go home and suddenly magically know what to do in day-to-day life when they're stressed and they really want to eat some potato chips, and they got to figure out how to avoid that. It's not going to work. So we thought, well, what do psychologists do best? We help our patients make behavior change. And so we developed a program which was a single session program that can be delivered by social workers, nurses, et cetera. It doesn't have to be a behavioral sleep medicine provider, but it's focused on these sleep hygiene suggestions, but operationalizing it in a way that matters to patients, which means identifying for them what their individual challenges are, the biggest ones, talking about ways that they can actually systematically make that change, giving them an expectation for how long they should expect to wait before that change improves their sleep, and all of these things that we know help people do things better consistently. So in that particular step care trial, what we did was we went into our clinics and we got individuals who were struggling with sleep. We followed them for a month. And we wanted to see if their insomnia would disappear. We actually do know that for a proportion of patients, because insomnia waxes and wanes, that they may actually, well, no longer struggle. So we didn't want to capture that piece. We wanted people who really felt like they were having chronic insomnia. And then we delivered what we called our SLEP1 program, which was essentially sleep hygiene on steroids, if you will. It was that 1 hour session where we really went through all of the things that matter for individuals in their sleep, but then we talked them through how to make those changes effectively and consistently. And then we followed them for a period of 3 months. Every 4 weeks, we assessed their insomnia again to see what happened. If at any point during that 3-month follow-up period, they had insomnia still, or it came back, we referred them to step 2 of our program. And step 2 of our program was the 3-session program that I showed you a couple of slides ago, which was talking about dosage. And that was more CBTI. If they didn't have any insomnia symptoms, they got nothing more. And then we followed them again for another month after their last intervention visit. What we saw with this lower dosage, step 1 and step 2, at baseline, people reported elevated insomnia symptoms. And then after treatment, because in both cases, it was delivered in week 1. Step 2 had 3 sessions over 4 weeks. Step 1 was 1 session in the first week. We followed them both a month later, and what we saw was for both groups, significant improvements to their insomnia severity. In fact, step 1 alone, we saw that half of our participants no longer had insomnia symptoms after that single session visit. And I want us to think about this group as the really low-hanging fruit in our clinics. So if you believe that about 1 in 4 to 1 in 3 of our survivors have insomnia, we can knock off a whole lot of these individuals, really change their lives with something that is very low intensity and doesn't require specialty expertise. Of course, you'll argue that there's half of these participants who continue to struggle with insomnia. And in this case, a lower dosage, in this case, 3-session program, can effectively cure insomnia for the vast majority of these individuals. And if we adopt an approach like this, we balance out the costs and the burden of providing this care with being able to provide people with a level of care that matches their current need. Now, I do want to emphasize that this is obviously not just work that I've done. Sheila Garland published a couple of years ago a really beautifully written systematic review of this work. There is some remarkable work that has been done across Canada and the United States that, well, the conclusion is this works consistently, no matter what disease population we're talking about at our cancer centers. I encourage you to read this particular review to give you a sense of an overview of what the approach looks like, as well as the data that shows across so many different programs how effectively this works. Now, I'm going to come back to that slide that I opened this particular talk with, which is this idea that patients and good science should drive SWOG members towards what you do in your clinic. I'm hopeful that if I haven't convinced you with our data, that you read Dr. Garland's work and you see that this is something where the science tells us CBTI should be what we do. The patient voice is something that's often lost in our care. And I do want to share here that patient care is really hard to do consistently, effectively, to the breadth of issues that need to be done in a survivorship visit. These are those survivorship care guidelines that I talked about earlier. It's a 141 freaking page document. At our center, our survivors get a 1-hour visit, especially if they're talking about 5+ years post-cancer treatment. And that happens annually, or perhaps once every 2 years. It just means you've got to talk about a lot of stuff. And for a lot of you, you may be thinking, well, how do I fit another thing into an hour when I've got to check about cardiotoxicity, depression, whatever the case might be? And we've shown that we can probably do a pretty good job of doing this. So the Insomnia Severity Index is that outcome measure that we used in our trials. It's a 7-item measure, so it takes less than a couple of minutes to complete. And in our population of 18 to 39-year-olds, we looked at it and compared it to the structured clinical diagnostic interview, or the SCID. And that 7-item measure, depending on what your preference is for the sensitivity and the specificity that you are seeking, does a really good job of picking up insomnia. So I want you to at least take away the message that if you're not doing it in your program presently, the burden in terms of time for completing a 7-item questionnaire is obviously not large. And if you do identify it, there are treatment options to consider. Now, all of this being said, what I have found in my clinic time and time again is a patient is going to come to see me if their oncologist tells them to come and see me. They can see every single publication available online, every single Dana-Farber blog article, every single news source. If their oncologist tells them that their sleep can be effectively treated, and there's this guy that I know you should go and see, they're going to come and see me. They're going to stick to treatment because they believe in their oncologist. They believe in you because you were likely the person that saved their life, and they trust you for their care. So in terms of, I hope, why that should matter, this particular video, we asked somebody who completed one of our trials, and she was very grateful for the work that we had done in terms of what her experience was like. So if it's okay, I'm going to ask you to turn on your speakers, give you a second to do that. And it's a question to ask her, well, what does this mean for you? So I'm going to hit play and hopefully all can hear.
I always feel like cancer is one of those things that takes so much from you, and it really kind of takes so much of that confidence in your own body away. So as simple and as silly as it sounds, being able to take control of your sleep is just one more way of like kind of taking your power back. And it feels like I could go anywhere, like I could go on vacation and, you know, maybe everything could be kind of messed up. I sleep later or I go to bed at a different time. But now I know that I have the power to really control my sleep. Whereas, like I said, for 15 years, it really controlled me. And maybe the whole time I actually had that power. I just didn't know how to harness it. So now I do. So I feel like it's just something that you just have to do. I mean, I can't recommend it enough. It was seriously one of the best things that I've ever done for myself because I am sleeping like more. I mean, some nights I get 9 hours of sleep. I never wake up in the middle of the night. And every morning my alarm goes off at 7:30 and I wake up and I'm like, like refreshed and ready to start the day. I'm not dragging myself out of bed. It has been such a total change. And you never, when you're not sleeping, you never realize how important sleep is. But all your doctors will always tell you it's so important to get sleep. It's so important to get sleep. And when you're sleeping, you really kind of feel how important it really is. And I can't imagine going back to where I was before. And I can't imagine living my life that way. But I did it for a really long time and way too long. And I really just wish that I had, you know, I could like go back in time and have done this 10 years ago. But I'm here now and I'm like, couldn't be happier about it.
So I appreciate your time, your willingness to listen to me rant and rave about sleep this morning. I hope that there are good questions that we can chat about. I've left some time to be able to do that. So thank you all.
Thank you so much, Eric. Really impressive work that you and others are doing. And I'm certain that our over 100 attendees that heard your presentation have learned a lot and will hopefully incorporate some of it into their clinics and or into their research. So there are some questions. Hallie, do you want to alternate or do you want to look through the chat?
So yeah, go ahead. We can start with Dr. O'Rourke's question, perhaps. And that is the geographic barrier to getting sleep CBT an issue of few providers or lack of access to mental health care in general, or lack of CBT for insomnia in primary care and or specialty care?
Probably all of the above. One thing that I encouraged at least Dr. O'Rourke to consider there is CBT is it's 3 letters that's often used to describe treatments for many other issues. Cognitive behavioral therapy is used as the standard of care for depression, anxiety-related disorders, PTSD, and it's not the same thing as CBT for insomnia. And so I do hear from patients time and time again that they went to go and see somebody for CBT, but they didn't learn anything about sleep, which is unfortunately the reality. So the specific issue of not having enough individuals trained in CBT for insomnia is a very real one. As a result of that, having providers embedded in primary care sites, specialty care sites, is just such a major barrier for the access to this particular approach.
Great. Thank you. The next question is from Vanu saying, I wonder if intimacy before bed helps or hinders sleep hygiene.
That's a great question. So part of the program that I mentioned earlier that was the most impactful was something called stimulus control, which is the avoidance of the bed for anything other than sleep. People typically think about this as, say, reading in bed, watching TV in bed. But for clinicians, what we worry the most about is sleep effort. That somebody with insomnia, if you've ever had a night where you couldn't sleep, where you lay in bed for hours potentially, trying really hard to go back to sleep, because that's all you want. You don't want to get out of bed. That conditions your body to become hyper-aroused in bed. You hate bed and you don't sleep, and it perpetuates the problem. So for actually the patient that you saw in that video just now, one of the best things I think she ever told me was that she actually told her husband that she was no longer going to have sex with him in bed during the entire course of the intervention because I told him not to do anything else in bed. And while she might have been taking it to an extreme that perhaps I wouldn't recommend for everybody, this idea that you should exclusively use your bed for sleep is a powerful one. And, you know, if we think about other conditioned responses, right? Like when we go into our mother's, our father's, our grandmother's home, we feel safe and we feel comforted just walking there, being in that place because it's associated with good things. Well, for a patient with insomnia, their bed is associated with a lot of confusing and problematic issues. So we want to use that bed just for sleep. And in this case, Banu, if they have sex, maybe we'll forgive them for it.
Great, thank you. Hallie, do you want to read?
Actually, it's Dr. Barrackos. Do you want to ask it yourself since you're up here with the panelists?
I am up here. I'm very interested in what you've said and hope to make contact with you at a later time. I'm particularly interested in research tools. So if I were doing a research inquiry related to fatigue, cachexia, the kind of things I'm primarily interested in, and I wanted to screen for sleep difficulties, and then if they screen positive, I would like to go on to follow up with a questionnaire. Which are the very best research tools for achieving these ends?
That is a wonderful question that I think would lead best to a longer conversation, especially with my colleague, Dr. Rakletis, who is the psychometrician and loves these kind of questions. You bring up fatigue. Fatigue is very commonly consistent and comorbid with our patients with insomnia, and it's hard for them to distinguish which is really which. In this case, that is a fascinating question, by the way, to be able to see patients with fatigue and insomnia, how to tease that apart. The ISI tends to be the one that's used mostly in order to assess just insomnia and not other sleep disorders. So we're not talking about sleep quality. We're not talking about things like apnea, RLS, et cetera, just insomnia. It tends to be the one, again, that is most likely to be used. And as I shared on one of my later slides, we validated against what is generally considered to be the gold standard of assessing for insomnia, which is the SCID insomnia module. And you can read that particular paper. I'm happy to share that with you in order to be able to assess insomnia in your patient population.
Thank you.
Wonderful. Thank you, Eric. Hallie, I don't see any other questions in the chat. Did I miss any?
Yeah, this is Lee Jones.
Lee,
I just have a
yes.
comment to make. Thank you so much for this presentation. As a survivor, I've never had anyone give me any guidance or counseling when I was going through treatment. Now, this was 17 years ago. My oncologist prescribed temazepam. Boy, I slept really well for a long time. And actually, it was only me that weaned myself off of that because, you know, that's not what his job was. When I was depressed, I got Paxil and again, weaned myself off it when I decided I had no reason to be depressed. But now, the three things you mentioned, I take Benadryl, melatonin, or Ambien if I have trouble sleeping, because I've had no guidance any other way. So for patients and survivors, this information is critical. And I just want to try to find a way to get it out to more clinicians so they can provide it to patients, but also through patient advocacy groups who have patients that are dealing with these issues and who can provide this kind of information, particularly if there are internet-based methods to help out, so we don't have to go through a clinic. We can do it ourselves if it really does work. So thank you so much, and I'm going to use this as a method to try to get more information to patients to let them know there are resources available.
Well, thank you, Lee. And Dr. Irwin, Dr. Moore, you weren't kidding when you said Lee would have good comments. And Lee, I am sorry to hear, although not surprised to hear, that 17 years ago, you were told that the solution was in a pill bottle. It is still the standard of care, as we've demonstrated in our studies, as well as in my patient contact today. So we haven't done much, or I should say that seems mean. We haven't done enough in 17 years. And I would be delighted if there were ways that we could work together to get this particular message out into the hands of people who would actually benefit from that information, because you're right. When you're not sleeping and your only choices occur in the form of melatonin, Benadryl, or Zolpidem, it's frustrating because it's a dependency upon something external to sleep. And they all come with their own price. And I don't mean the $8.99 you pay at CVS. I mean all of the things that we worry about. So thank you for that. And hopefully we do get a chance to connect. I actually see, I don't know, Dr. Irwin, Dr. Moore, I got a Q&A. I don't know if it's directed to me or to the audience, but one of the questions in that Q&A was accessing CBT online. So our program that we adapted for cancer survivors is not available. And that's a whole nother can of worms that I think this group probably knows better than others. You develop these great programs that get funded, and then they just sort of sit on a shelf looking pretty. How do we get that into the hands of people? And I don't have a good answer for that, but Shut-Eye is available in a much older form. So there's a program called SOMRIST, SOMRYST. SOMRIST is based on a version of Shut-Eye that I think is about 6-ish years old, which means it's nowhere near as pretty as the current research versions of Shut-Eye, but the meat is there. The reason why it's the 6-year-old version of Shut-Eye is because that's how long it takes the FDA to approve this kind of a thing. And so your patients will be receiving something that's a little bit, it'd be like using an iPhone 5, if you will. Does all the tricks, but doesn't look as nice. They can be prescribed this. You can actually potentially get reimbursed, or the patients can get reimbursed for this. So that is one option for the general community. There is nothing in there about cancer survivors or patients, though. So the questions that people commonly ask, like, what if I have hot flashes? What if I'm taking a medication that causes me to be fatigued during the day? All of these things that we know happen at our cancer centers isn't addressed by the program. But I think for a lot of people, just standard CBTI would be more than enough.
Sounds like there needs to be some implementation science grants funded on how to implement these sleep interventions, internet-based, but a part of the oncology care clinic.
You know anybody, Dr. Irwin, that can connect with me?
Yeah, so I'll send you some a follow-up email. There is 2 more questions in the chat. I'll read the first if Hallie, you want to take the second. So Lauren Fowler asked, how would you use actigraphy measured sleep efficiency as a measure of insomnia? And do you have to show specific fragmentation patterns at onset or termination or within a defined period overnight? People can have poor sleep efficiency without technically having insomnia. So just wondering how to quantify it.
Yeah, it's a great question, Dr. Fowler. So the actigraphy measured sleep efficiency, which I had shared, is what Dr. Palish used in her study among metastatic stage breast cancer patients, was a nice way of essentially convincing oncologists who really like hard numbers that there's something there. It's not some self-report measure of sleep, which we often get dinged for in our grant submissions. Now, first is insomnia is measured and assessed and determined by self-report. It's a subjective disorder. There is no need for a sleep study or an actigraphy measurement to determine insomnia disorder as a diagnosis. If you're looking for a cutoff and you have actigraphy data but no self-report data, we typically think of that 85 or maybe 90, depending upon what your preference is, as a cutoff for good versus bad sleepers. Now, is it possible that somebody has really poor sleep efficiency and doesn't have insomnia? I suppose, partly because any diagnosis of insomnia disorder requires that that patient has some consequences, that they're bothered by it. It's sort of one of those necessary DSM diagnostic criteria, right? If you can't sleep, but you love your life, technically you're not diagnosable with insomnia. So yes, it's possible to have poor sleep efficiency and not be diagnosed with insomnia, but that tends to be not that common. Because if you are, going to bed and spending 2 hours a night not sleeping, there tend to be consequences as a result. But the specifics of whether or not you need to have fragmentation patterns, not really. And we actually don't know whether people who have sleep onset issues versus sleep maintenance issues versus early morning waking issues are worse off. It's actually a field that I'm not aware of very good data to discuss.
Thanks. So Dr. Hirschman has a question that might be a nidus for a clinical trial idea. Dr. Hirschman, do you want to share your question?
Oh, sure. Yes. Thank you for your talk. It was really great. I'm just wondering, in terms of the cardiovascular linkages with sleep and chronic comorbidities, if there have been any studies looking at sleep and subsequent risk of cardiovascular disease in cancer survivors?
Yes, and they tend to look at, when they think about sleep, generally breathing related sleep disorders, because we know so convincingly that disorders like sleep apnea exacerbate the development of and the symptoms of a lot of CVD outcomes. So in terms of insomnia specifically, not so much. And one of the reasons is because, so in cohort studies where we get a lot of this good data between sleep and cardiovascular outcomes, their outcome or their predictor or exposure, I should say, variables for sleep are not great. It's like, how long do you sleep? Do you have any difficulty with sleep? It's not really true insomnia. So Dr. Redline, Susan Redline, out at Brigham and Women's, has done spectacular work looking at cardiovascular health outcomes, not in cancer patients specifically, but in the general population. And so if this is an interest of yours, there's a lot of space where I think that work should and could get done. And I'm happy to introduce you to Dr. Redline if you're interested in learning more from her, since that would be much more her wheelhouse.
Thank you. Another sex question. I think we'll make this our last question so we can then hear from Dr. Redding and her new sleep study. But Marta Wood asks, with regard to sex, it is well known that one of the many ways cancer affects quality of life is by affecting sexual well-being. So couldn't sex in the bed help to reestablish the bed as a safe and positive place?
Yeah, absolutely. I mean, I was being a little bit facetious earlier in saying that we should never, ever have sex in bed if we have insomnia. Absolutely. I think that is something that's an important part of somebody's quality of life and well-being overall. It just means that we don't want that patient after sex to spend 2 hours trying to fall asleep if they have sleep onset insomnia.
Great. Well, thank you so much, Eric. This was a fantastic presentation, a lot of new information, very important information. So if you don't mind hanging on and hearing from our first presenter to the IMS people, if you want to pull up the PowerPoint slide, that would be helpful. Okay, great. So just to let you all know that myself and Hallie, I don't have anything to disclose, and Hallie does have research funding from her institution. You can see that there. And then the next slide. Okay, so Dr. Karen Redding is going to present her newly funded sleep study. I'm seeing only half of the PowerPoint slides. What are others seeing?
We can see
the whole thing.
You can? Okay,
Yeah.
maybe it's, okay. All right, Karen, take it away.
Thank you. Well, Dr. Zhao, it was really fantastic to hear your presentation. It was engaging and certainly motivating. So I'm going to be presenting a Hope Foundation funded project called CCBot. It's a chatbot to improve sleep in breast cancer survivors. Next slide. So today I'm going to give a background, some preliminary data, the aims of the Hope Foundation grant, and then talk about the development that's underway as well as our work that's underway. Next slide. So Dr. Zhao did a fantastic job of providing background, so I'll go through these rather quickly. But a majority of breast cancer survivors report sleep dysfunction both during and as well as after cancer treatment. And as Dr. Zhao mentioned, patients can report sleep dysfunction as one of the most distressing symptoms. And also, as he mentioned, there is a racial and ethnic disparity in sleep dysfunction, as well as a less likelihood of receiving care for sleep dysfunction. And as we all know, sleep dysfunction is associated with increased risk of fatigue, depression, and reduced quality of life. And similarly to Dr. Zhao, I would make the point that by addressing sleep, then these outcomes can often be ameliorated. Next slide. So a little background on our chatbot intervention. So, you know, what we see and what was also presented by Dr. Zhao, so a great lead-in really to this presentation, is that face-to-face interventions are intensive, and they can also be limited by geographic barriers. And chatbots, on the other hand, can deliver education and behavior change strategies by engaging users in goal setting, activation, and motivation. So being able to deliver a CBTI via a chatbot can reach more people and have wider dissemination. And in the literature, we see that users of chatbots report a willingness to share information. And in fact, in the literature, there is some indication that patients are more likely to share what they would view as sensitive information to a chatbot because they're not as worried about being judged or having, you know, something embarrassing be delivered to a non-human interface. So our CCBot chatbot is delivering a cognitive behavioral therapy for insomnia, as well as a physical activity intervention. So next slide. So what we came up with in our preliminary data were, you know, the barriers that were present for women who were looking to get help with sleep difficulties. And, you know, the top one, almost a third of women said, I don't feel that I need help. But when you looked at the next two highest ranked reasons for barriers of getting help, was they couldn't afford the therapy of CBTI delivered in person or other forms of help. And they also didn't know where to start. So this was useful information for us to have that supported the use of a chatbot for sleep. Next slide. And we also saw somewhat interestingly that if we looked at how easy or difficult it was for women who were in our age demographic for breast cancer, there was overwhelming support that it was easy to follow texting. So the far left green bar, and there was less, ease with learning how to use a new app or learning a new technology. So we decided to deliver a short message service, so SMS or text, what we think of typically as text chatbot, to be the most appropriate modality for this population. And we also chose SMS because it was the lowest barrier modality for delivering to a wide range of breast cancer survivors, and felt that it could help even in rural settings where bandwidth might be lower, and gave us the chance to widely disseminate. Next slide. And so our Hope Foundation project has two aims. First is to examine the feasibility and acceptability of a 6-week CBTI plus physical activity intervention delivered via the chatbot modality, and then explore the effect of this intervention on improving insomnia, physical activity, quality of life, fatigue, and depression. Next slide. And so the chatbot overview, as I mentioned, it's a text-based intervention, and it's designed to be a standalone CBTI experience. So it doesn't require the use of an interventionist to be in the shadows. It's actually, delivering just via text. And it's a low-cost alternative to traditional therapy. As we mentioned, that we wanted to do a low-cost one given our preliminary data. And as I said, it centers on this SMS. So as you can see in your in the image, it's basically the CC bot is reaching out via text. There's no app that has to be downloaded, and the person replies back, and there can be then a chat back and forth. And it's highly focused on using forced text responses rather than having you know, an AI informed algorithm in the background that's parsing through the words. It's more, it asks a woman, you know, what is your primary sleep concern? It might be delayed sleep onset, etc. And so the forced text response allows us to create one that requires less AI in the background. Next slide. So the design guidelines, we focused on these major areas. So bot introduction, how does CC bot present herself to the patient? And then how do we get to know what the user's experiences with sleep, what their characteristics are? So, and these are the pieces of information that would help tailor the intervention. For breast cancer survivors, one of the important things is to learn whether or not she's on endocrine therapy, because that might be associated with vasomotor symptoms that would be interfering with sleep. Then the chatbot delivers an education. And so this is providing knowledge on CBTI and physical activity and how this is useful in improving sleep disturbances. Then there's goal setting. So that's establishing a plan around a woman's plan for the next few days for physical activity. And that's something that's rolled out every few days or twice a week. Also goal setting around sleep compression, as well as sleep hygiene. And I'm going to get into the sleep hygiene. That was really interesting to hear about Dr. Zhao's work with sleep hygiene. And I'd be interested to hear his thoughts and see if ours is kind of achieving that mark as well. Then there's a just-in-time adaptive intervention. So it's tailored feedback that would be given to a user on meeting their goals. So this, for example, could be if a woman planned to do exercise on 2 of the following 3 days, and you get to the 3rd day and so far she hasn't, there could be some encouragement of reminding that a goal had been set and checking in to see if she's achieved that. And then tracking. So that's basically a dashboard where women could see how their sleep has been going using Fitbit and user inputs. And this dashboard would also pair up some of the triggers from sleep hygiene, for example, the coffee example. So if a woman has been reducing her coffee intake after, say, 2 p.m., we would be showing that progress as well. And really, this is all grounded in the tone of CCBot having empathy. So having empathy through encouragement and positive motivation so that it's a welcoming place for a breast cancer survivor to receive this support. All right, next slide. So this is just an example of our design work. We come up with our flow charts of what CCBot will say, what questions CCBot will ask, and then that goes on to a flow chart of going through the next questions based on those responses. So next slide. So CCBot intervention, CC is going to deliver a text message technology paired with Fitbit, and it's adapted from a CBTI web-based intervention that is out of the Cleveland Clinic through our collaborator, Michelle Drerup, and it provides these interactive and individualized features. So as I mentioned, there's education and goal setting. So each of the educational modules will be designed to be completed within about 10 minutes, and those are delivered 2 to 4 times a week that are tailored to user inputs, such as if a woman reports that she uses sleep medication, then there would be an educational module on sleep medication for her to learn more about how to reduce her use of that. Then there's also this just-in-time adaptation, so a just-in-time adaptive intervention that's focused on accountability and recognition of meeting goals around physical activity, sleep compression. So that's an algorithm that's built in the chatbot to help a woman achieve sleep compression in one of the first sets of the education and goal setting modules. And then, as I said, hygiene. So that's basically asking individualized information around what are the triggers that are causing a poor sleep. So for example, late in the day caffeine, and using that detailed information to personalize the intervention for the woman. And then we also have bedtime reminders. So that's something that we received information from our users when we were conducting user testings and what we refer to as our 1.0 CCBot development phase. And in that, we learned that women would like the idea of having CCBot say, it's about 2 hours till your bedtime. are you, getting ready for everything and, that you need for bed? Are you starting to wind down? Would you like a relaxation audio file to be sent? And so women can set when they want that bedtime reminder, if they want it an hour before bedtime. And they really endorse the use of these audio files for relaxation that they could have. And then our new features are hopefully what we're working on now is being able to allow a woman to rank those, favorite those audio relaxation files and be able to have one available on demand. And then this, as I mentioned, a personalized dashboard that helps them to see their sleep and physical activity data and then see how that's relating to some of the barriers and triggers that they may have brought up. All right, next slide. And so we're currently in development. We are working iteratively with our developers, Moby Inc., a local firm, and we're basically working on providing enhanced features from our 1.0. And I think I've mentioned some of those. So in the interest of time, I think I've mentioned most of these ideas of tailored education and recognition for meeting physical activity goals. So next slide. And then so at this point now, for the pilot testing, we would be exploring the impact of CCBOT. And this is a 2-arm randomized trial with a 2-to-1 assignment to CCBOT versus usual care. And this is post-treatment breast cancer survivors who are experiencing moderate to severe sleep disturbance that we're assessing through ISI when we screen participants. And it's a single site enrollment currently using the Seattle Cancer Care Alliance network of Seattle-based regionally cancer clinics. And then we're going to be oversampling marginalized groups because we're interested in determining if this is meeting the needs of lower SES women as well as race and ethnicity minority groups. Next slide. And so I just want to acknowledge the Hope Foundation Impact Award. It's really exciting to be able to move this project forward. Our team is comprised of SWOG investigators Heather Greenlee and Rachel Young, as well as Fred Hutch investigator Jamie Hefner, and as I mentioned, Michelle Drerup, and my team here below that, as well as I wanted to acknowledge the UW Center for Innovations in Sleep Self-Management that was funded through the National Institutes of Nursing Research and the faculty and staff involved with that. So I would now turn it over to questions. If anyone has questions for me, I'd be happy to answer those if we have time for that.
Wonderful. Thank you, Karen. I wonder if Dr. Zhao has any comments or questions he wants to share.
Yeah, Dr. Redding, I always see this kind of stuff and think, damn it, why didn't I think of something like this? This is fantastic. The only comment that I have is we're working on something that uses smart speakers to develop CBTI. And one of the things that I find to be most valuable from a clinical perspective is being able to be in the home of patients. Because if I see somebody in my hospital clinic, I see them once a week, once every 2 weeks, perhaps. And it's the interim period in which they're executing the changes in which we know patients struggle. And so being able to, for you, actually, it sounds like in vivo track poor sleep, perhaps non-adherence to a sleep compression recommendation, and being able to then provide immediate feedback. I think that's, if you're not already doing it, supremely important to at least consider.
Yeah, thank you. Yeah, I kind of sped through that, but there is, there's as much as we can do with SMS and forced choice responses. We're going to be checking in with women on their sleep compression, and then, making adaptations when there's some resistance perhaps to the recommendations given. Yep.
Thank you. Karen, you mentioned in your PowerPoint that you adapted this from, was it from an internet-based intervention? I was just, because of the question earlier, someone asking about an internet-based intervention, what one you adapted it from?
Right. So actually it's 2 parts. So for our CCBOT 1.0, we used a telephone-based CBTI for women who were experiencing menopausal transition symptoms. So hot flashes. And so we felt that worked well for this population who, because of the use of endocrine disruptors, would potentially be having similar issues. So that was CCBOT 1.0. And then for now, this Hope Foundation Impact Award, what we're calling CCBOT 2.0, we're using the Go to Sleep intervention. That's a web-based intervention at the Cleveland Clinic. And so that one, I actually was thinking about that earlier when someone asked, are there tools available? And I'm not sure how widely available that one is, but it's got educational components and basically all of the CBTI features.
So
What's
I
it called
comment
again?
on- I'm sorry, I can comment on this Cleveland Clinic tool. It's
Yeah,
called
yeah.
Go to Sleep. If you Google Cleveland Clinic Go to Sleep, you'll find it. And anybody can access it, but it's like a $40 fee. But then it's a 6-week program, I think.
Great.
Thank you.
Wonderful. In the interest of time, I will just read this one perfect comment that this study is loved. And are you planning to write a grant to do this through SWOG once you have your pilot data?
Yes, indeed. That's the next step.
Okay, great. Wonderful. Well, thank you, Karen. And thank you, Dr. Zhao. This is really inspiring. It's a ton more research needs to be done. So hopefully maybe there'll be more concepts through SWOG regarding sleep, and know to reach out to some of the experts today, Karen and Dr. Zhao. Thank you so much.
Yeah, good luck with this. Yeah.
And Karen, if you stay on, there might be some more chat questions if you can respond to those. Thank you.
Sure.
And thank you, Dr. Zhao.
Yeah. And then next, before we get on to the study concepts, I'd like to give Lee Jones a chance to provide the advocate update for us.
Great. Thanks a lot. And thanks to both of you, both Dr. Moore and Dr. Irwin, for the guidance you're providing to this committee and the excellent work we've been doing. First, I'd like to have a shout out to Dr. Barrackos. I have the privilege of being on a team with her looking at putting together a proposal for a Cancer Grand Challenges grant to study cancer cachexia. This is a multinational grant program, and the proposal was due yesterday. So I'm surprised to see her alive and well and awake this morning. It's earlier for her than it is here, but thank you for all the work you're doing on that, and looking forward to hopefully 5 years of work on this project. Those of you who heard Dr. Blanke's plenary 2 session yesterday knows the emphasis that he and SWOG are putting on diversity, equity, and inclusion, including some of the resources he's planning to bring onto SWOG to help us all do better in those areas. And so in addition to those resources, I want to let you know that we've developed a new training module, which is number 6 in the series of team science that's focused on these DEI issues. And starting off, all the advocates have had to take the training. I think next will be the committee and study chairs, and then it'll be open to everybody. But there's a very useful field guide that provides practical advice and insights into how to improve the diversity of the patients on our clinical trials. So I'm looking forward to everyone having an opportunity for that. And it is something that obviously all of SWOG is going to be focusing on over the next few years until we do better. I was surprised to hear Dr. Blanke say he's not going to be doing any more Jewish jokes because of its obvious issues, even though he's Jewish and was therefore felt he could do that. Sort of related is I wanted to let everyone know, remind everyone that we brought on community advocates in addition to those of us who you're more familiar with as research advocates through the years. These community advocates represent patient populations that are of special interest to SWOG. And currently we have 7 of them in place. Let me just let you know which ones groups they represent: adolescents and young adults, rural residents, LGBTQ, Asian Pacific Islanders, Latinx/Hispanics, older adults over 65, and military veterans. And yet to be selected, we have 3 more in the works: caregivers, advanced/metastatic cancer, and African Americans. I encourage everyone to think about how we can use these community advocates, both in the design of our studies, but also in the implementation of our studies, to perhaps find ways to access some of these special populations that we maybe have trouble accessing, and also maybe think about how we can use them to help us identify the needs of survivors in some of these groups that we maybe don't think of so often. So we can make our survivorship studies more representative, more inclusive, and be useful to a broader diversity of patients. And kind of the last thing I wanted to do, as you've all heard me say many, many times, I think we should try to find ways to include more cancer types within our studies. Survivors need to have better information on things that will help us sooner rather than later. And waiting to go through the series of, well, let's do cancer A. Okay, 5 years later, let's try cancer B, see how it works on that. You know, let's do multi-cancer studies, umbrella types of studies, so we can see, I mean, if a sleep intervention is helpful for breast cancer patients, why couldn't it be also helpful for colorectal cancer patients, melanoma patients, lung cancer patients, et cetera? Clearly, some cancers and their treatment preclude them from being in certain types of trials. For instance, if you have bone metastases, you're probably not going to be on an exercise intervention, or maybe a different exercise intervention than typical. But I encourage people to think about this and find ways that we can speed up the process so we can get good results to survivors to help them improve their quality of life. That's all I want to say. Thank you very much for the opportunity.
Thank you so much, Lee, for your continued advocacy, and you always bring such important information to our committee, so very much appreciated. Okay, Hallie, should we go back to the PowerPoint?
Yeah, and Dr. Floyd, do you want to update us on S1501?
Sure, can you hear me?
Yes.
All right. Yeah, we can go to next slide if you want. So just a brief update on 1501. This doesn't really project well on my screen. I'm seeing about 3/4 of the slide, but hopefully everyone else can see the full screen. Is that the case?
I see it all.
Looks
All
good.
right, good. So you've all seen this. Is just briefly a schema of 1501. We're taking women that are, or men that are metastatic HER2 overexpressing breast cancer patients at high risk for cardiac dysfunction from HER2 targeted therapy, and randomly assigning them to receive either carvedilol or no intervention, and following them for the endpoint of a decreased ejection fraction and multiple secondary endpoints. Probably significance on this trial, we have sort of grayed out the non-randomized arm. So that has completed accrual, reached its goal, and that's been closed. So currently, the only arms of the study that are open are the randomized arm, either carvedilol or no intervention. Next slide, please. So here's our accrual listed here to date. We have 256 patients registered to date. Let me move this so I can see my slide. Sorry for that. And you can, in the top left, you can see sort of the top accruing sites. And as you can see, there are sites that are really able to accrue robustly to this trial, and would like to, reach out and say thank you for your accrual. We really appreciate all your help for everyone, whether you put on 1 patient or 43 patients, we appreciate it. So we are moving along. You can see then on the bottom left, sort of our progress. I would say we've sort of evened out around 5 patients a month or so, and we'll probably, hopefully trend up from there, but probably will not skyrocket up for there, if nothing else, because the third observational arm has been closed. So that will slow accrual somewhat. So just a few highlights. As I said, the observation arm has met its accrual and closed. We have put through a couple of amendments. We're allowing up to 4 lines of therapy now, which I think will increase eligibility criteria, loosen restrictions, and hopefully make more patients eligible. Through a lot of work, thanks to all involved, we did finally receive the approval to proceed with a champion through the alliance mechanism. There had been a lot of talk back and forth about this. So Catherine Ruddy from Mayo Clinic's our alliance champion. So she's promoting the trial through alliance, and I don't know if it's happenstance or because of this, but we have had several sites approach us since then about getting involved with the trial. So that's good. We have started analyzing our baseline neuregulin data, which that is one of our translational endpoints. So that's exciting. More to come on that. And we're still actively recruiting sites. And I would just encourage you to check to see if this is open at your institution and email us if you have questions. So thanks for letting me present briefly.
Thank you. But we can probably go on to the next slide. I'm not sure which one's up next, S2013. So Dr. Gunteru, do you want to share us about the progress on iCheckIt?
Thank you very much. And you can go to the next slide. On behalf of S2013, iCheckIt, the study is open and we have 4 patients on the trial to start with. So the primary objective of this study, which is a prospective observational study, is to develop and validate a risk prediction model for IRAEs, which are CTCAE grade 3 or higher non-hematological immune-related adverse events for patients who are receiving immune checkpoint inhibitors, ICI therapy in the first year for the treatment of solid tumors. Can we go to the next slide, please? So the secondary objectives is to also assess the incidence of non-hematological IRAEs, any grade, and also grade 4 hematological IRAEs. So the main objective, secondary objective, is to look at the chronic toxicities which burden our patients and which do not make it onto the clinical trial report, or grade 1 and 2 toxicities, and also patient-reported outcomes of their quality of life or patient-reported adverse events. So those are our secondary objectives. Next slide, please. So any solid tumor patients receiving ICI per FDA or NCCN category 1 or 2A are eligible to participate in this study. They would not be eligible to participate in another clinical trial, treatment trial participation. They should be receiving immune checkpoint inhibitors alone or with another immune checkpoint inhibitors, not with the chemotherapy or biologic therapy or targeted therapy. They should have received, if they received ICI before, they should have recovered sufficiently from the prior treatments of other treatments. And also if they received ICI, it should be more than 180 days. Next slide, please. So our goal is a hefty goal of 2,000 patients, 2,062 total for the ineligible and dropout, and it would come to like 57 participants per month. We're proactively planning to reach out to NCOR sites and also with the Latin American initiative from SWOG to improve diversity and inclusion in these trials. PROs are also in Spanish and French for this trial. The stratification factor is patients getting ICI monotherapy or combination therapy. Next slide, please. So this is the study calendar. Initially, patients consent and register. They get a standard of care labs and other workup for the treating oncologist, and they go on ICI therapy. Before they start, they would also get a concomitant medication history, CTCAE toxicity assessment, and they fill out PROs. If there is a tissue available before, then we would request that tissue. They do not have to undergo another tissue biopsy for this. Next slide, please. They would also get a baseline blood test at this time previously, prior to registration and starting ICI therapy. This is the detail of the pre-registration procedures. Next slide, please. And in addition to the baseline, there are 4 other time points. We also get concomitant medications, CTCAE, PROs, and standard labs, which includes week 4, 12, 24, and 52. There is another blood draw at week 4 with a 14 days window and at the development of grade 3 or higher toxicities. One thing to remember is even though we're collecting the time points as these, we encourage sites to assess the CTCAEs so that we know when the grade 3 IRAEs develop, Next slide, please. And all ICI, until even if they're discontinued for 1 year, they will be provided. These are the patient-reported outcomes, which we're going to get on this study. One includes fact G, I'm bothered by the side effects of treatment, but also proven to show the adherence and how participants are feeling. Next one, please. This is the translational objectives of cytox score, which is a composite measure from 11 different cytokine levels, which we get from like both prior to ICI therapy and after 1 cycle. We're establishing a repository for archival tissue and blood specimens, plasma for the potential predictive and prognostic markers for the IRAE risk. Next slide, please. So this is a simple schema of the study. When participants consent and register, they go on their baseline evaluation. They continue with their standard treatment, and at these time points, we evaluate for their CTCAE and PROs, along with when they develop grade 3. We also encourage participants to take part in Alliance trial, which is looking at grade 3 or 4 higher toxicities. And at 52 weeks, the trial participation will be complete. And next slide, please. So this is, in summary, this is a study for patients who are receiving immune checkpoint inhibitors who are not going on clinical trial, where we see these patients all the time in our clinics, and it is applicable to multiple solid tumors. So please consider opening this trial at your institution. And there is also a social media kit for this study with the plain language that our digital engagement team worked on. And it would be hashtag with iCheckIt, which is coming to Twitter soon. Next slide, please. I'd like to thank my whole S2013 team and SWOG for this opportunity. Thank you.
Wonderful. Thank you, Krishna. It's so nice to see this study moving forward. And you said you've already enrolled some participants, correct?
That's right.
Good, great. Congratulations.
Thank you.
Okay, just keep an eye on the chat box or Q&A if there's any questions. We'll move on to Dr. Sai.
Hi, good morning. Can you all hear me?
Yes.
Perfect. I think many of you, at least on the panel, may know me already, but by way of introduction, my name is Katie Sai. I am a melanoma oncologist at UCSF, and I wanted to thank Drs. Moore and Irwin for allowing me some time to present. Many of you may already be familiar with this study. You've probably been involved in inception and in refining the design, so thanks for the opportunity to provide an update. By way of background, we know that immune checkpoint inhibitors, or ICIs, as Dr. Gunter just described, are very in wide use now, not only in melanoma, but since 2011 are now approved in a wide swath of solid and liquid tumors. Not only that, but the trend has been to move it towards earlier and earlier stages of disease. In melanoma and in esophageal and gastroesophageal junction cancer, for example, PD-1 inhibitors are approved as adjuvant therapy. And in melanoma, it's also really in wide use as a neoadjuvant agent as well. So despite widespread use, the effects of immune checkpoint inhibitors on human reproductive function really are poorly characterized compared to in the chemotherapy world. And that is additionally despite plausible direct and indirect mechanisms of gonadal toxicity. So we're improving survivors, increasing the number of survivors in the melanoma world. And I think alongside with that is recognition that perhaps there's space to think about family planning and other things that were perhaps not the focus 10 years ago. What that leads to really is very little information on the provider's end to help make decisions, and therefore wide variability in practice patterns, whether or not patients are referred to specialists for fertility preservation at all. Next slide. So the study proposes to take a first look within S1404, which I think is actually the next slide. But since we're on this one right now, the objectives really of this study are to use a pool of banked and frozen sera to look at serum markers of gonadal function in men and women. In women, the endpoint of interest will be anti-Müllerian hormone, or AMH, which is a direct measure of ovarian function. Therefore, a decrease in AMH correlates with a decrease in ovarian reserve. In men, the traditional marker of reserve has been FSH. Because of the negative feedback loop, an early rise in FSH actually can be an indication of a poor spermatogenesis. But inhibin B is in wide use in the reproductive endocrinology and infertility world as the more direct marker of decreased spermatogenesis. So those are the endpoints of interest. And if you go to the next slide, you can see that S1404, which is a randomized phase 3 study investigating standard of care, or I should say, previous standard of care for adjuvant therapy in melanoma compared to pembrolizumab, which has since been approved. But things I'll point out from this study schema are, number one, that all of the participants are ICI naive. The second thing I'll point out is that per study protocol, that there were sera collected at certain time points, including at baseline and on treatment. And there were over 1,000 patients randomized to the study, so a good pool to select from. Next slide. In terms of primary and secondary objectives, you can see that they're pretty straightforward. The primary objective was to estimate the effect of ICI on gonadal reserve in men and women. And given this, the time points at which sera were banked, the proposal was to look at baseline and week 25 levels. Secondarily, we would compare those changes adjusted for treatment arm. So there were folks who had a PD-1 inhibitor or a CTLA-4 inhibitor, and for age. Next slide. This is just getting a little bit into the nuts and bolts. So I mentioned the frozen sera from S1404. You can see the key eligibility criteria described here. And working with the statistical team, you can see that the initial feasibility assessment does show that there are 68 eligible women and 81 potentially eligible men. Next slide. This is also just a note that in acknowledgement that biospecimens are precious and to avoid wastage, that there was consideration for the minimum amount of frozen sera that would be required for the study. A lab has already been identified who would be a partner in helping to run these assays. You can see here also that transportation considerations were taken into account as well. Next slide. I think that even despite the relatively small numbers that working together with the S1404 biostatisticians, that given the pilot nature and first look of the study, that there was felt to be adequate power to be able to detect changes between baseline and week 25. So I believe this is the last slide, and I just wanted to take the opportunity to acknowledge that finding appropriate funding for the study has been difficult. The Hope Foundation has a particular mechanism called the Seed Fund, which is meant for pilot projects. This was initially applied to that funding mechanism last year. We were able to garner some very helpful comments and some acknowledgement that it was in very close running to achieve funding last year. We were encouraged to reapply. So we did reapply in December 2020, and I just received notice I think a week or two ago that unfortunately it was not selected for funding this round either. So I've gone back to the drawing board. I'm very interested to hear any thoughts or any leads you might think be appropriate for an appropriate funding mechanism. I have thought of, I have discussed this with our patient advocacy group, AIM at Melanoma. I've also been in contact with Becky Johnson from the AYA committee. but interested to hear any thoughts or constructive feedback at this point, either now or offline later. Sorry about the background noise. I'll mute myself now.
Thank you, Katie. I'm sorry to hear about the funding situation, but I think it's your approach of some foundations is worthwhile, and happy to discuss with you more offline. Hallie, any comments?
No, just that if anybody in the group has ideas, I think this is, it's not going to be a particularly costly study, and I think it's very worthwhile and important, and all the work's been done with the logistics of the study. So really just funding remains. So would appreciate anybody's ideas about potential sources.
Okay, so we thank you so much, Katie. We will reach back out to you. We are now going to pass it on to Virginia Sun. Dr. Sun is going to present the study she is proposing to do with Dr. Raz.
Thank you for the opportunity. I'm here to give an update on S2204, a randomized phase 3 trial, of perioperative physical activity intervention in older adults. So this is an older adult, 65 years and older, focused trial with lung cancer and their family caregivers. Dr. Dan Raz is a thoracic surgeon here at City of Hope and the study chair. He is in the OR today and unable to join us, so I'm here on his behalf to present the update. Next slide. We want to acknowledge our study team, our current study team. The study team will grow as we move through the process. We appreciate Dr. Irwin's support as the committee co-chair. I am a co-chair. Catherine Guthrie's support with biostatistical design. Of course, Lee's support in terms of the study design and the patient perspective. We also have got feedback from 2 of our nurse coordinators, my colleagues in the Nursing Research Subcommittee, Stephanie J. Smith and Dr. Krista Braun-Inglis, who are both play key roles within large NCORPs, one in Georgia NCORP and one in the Hawaii Minority Underserved NCORP. We wanted this feedback early so we can make this least burdensome and practical for all of our NCORP sites. And also Taj Pereira's support and protocol coordination. Next slide, please. Our primary objective is to compare clinically meaningful changes in objective functional capacity as measured by the 6-minute walk test at day 30 post-discharge between the intervention and an enhanced usual care arms. We have several secondary outcome here, looking at the 6-minute walking test at day 60 post-discharge, the short physical performance battery, which is an objective measure of lower extremity function at day 30 and day 60 post-discharge. We also have patient-reported and family caregiver-reported outcomes by way of self-efficacy, physical function, and quality of life. We also will look at time at home and away from the hospital, low versus high. We will look at hospital readmission rate and post-op complications. And 2 exploratory aims will focus on image-based sarcopenia, pre and post-surgery, and digital biomarkers of frailty using pedometer documented daily steps. Next slide. Our eligibility criteria for our patients include those that are scheduled to undergo a primary lung cancer surgery. Neoadjuvant therapy, those who have received neoadjuvant therapy are allowed. 65 years or older, at least 14 days before their surgery, and we are focusing on English and Spanish-speaking populations. Our definition of family caregivers listed here: a family member or friend identified by the patient and defined as a person who knows the patient well and is involved in the patient's care before and after surgery. 18 years and older, and ability to read and speak English or Spanish. Here, a key note here is that patients can participate without a family caregiver enrolled. Next slide. So very quickly, our dyadic perioperative physical activity is based on the chronic care self-management model. We've heard many of the key constructs in many of the presentations today is really looking at proactive planning and building self-efficacy. And our purpose is very much to be able to promote walking as a physical activity for our older adult population and their family caregivers before and after surgery, and even throughout really long-term their cancer trajectory and their journey. As part of the intervention, we'll be using many principles of behavior change. We are going to do goal setting. We're going to help them figure out challenges in terms of walking and help them problem solve around these areas, and also talk about pre-op coping and anxiety. So in the yellow box here, the coaching sessions We'll be focused on a personalized walking program, lower extremity exercises, signs and symptoms of exertion, of course, safety precautions, also using self-monitoring approaches using a wristband pedometer. We are using the VivoFit 4, which is a Garmin company product, and also coaching the family caregivers as walking buddies. So encouraging them to walk together, since we know that physical activity behavior change in terms of social support does have an influence. And then also they will have a resource manual. Next slide. This is our study schema. So our dyads or patients are also allowed to enroll if they have no family caregivers. After consent, we'll complete baseline assessment. This will include comprehensive geriatric assessment and the objective functional measures, as well as PROs. They will be randomized to one of these arms, two arms, the intervention arm or the enhanced usual care. The intervention arm is a telephone-based coaching delivered by trained coaches that have physical activity and physical therapy, occupational therapy backgrounds. And we will deliver the first session before surgery. They will have the resource manual, be given a VivoFit for self-monitoring. Patients will then have surgery. We will do discharge assessment, and 4 more sessions will be delivered, and day 7, day 14, day 21, and day 51. We will do day 30 assessment post-discharge, as well as day 60 assessment. The enhanced usual care group will receive the ASCO physical activity tips for survivors, written materials, and also be given a VivoFit 4, but they will not receive the coaching from the coaches. And so basically what they will be doing is utilizing the written materials and also using the VivoFit as self-monitoring. They will be assessed at the same time frame as the intervention arm. Next slide. In terms of our statistical design and recruitment, we will need a total of 228 evaluable participants to detect a 0.43 standard deviation effect size with 90% power and a one-sided alpha. To account for the potential ineligibility of 5% and really attrition at 15%, so a total of 20% overall, we will enroll a total of 282 participants. We will be stratifying randomization based on pre-op frailty index, age, and minimally invasive versus open surgery. So the robotic video-assisted procedures versus open procedures. Our primary endpoint analysis will be conducted using modified intention to treat principles. We are anticipating to have a 4-year enrollment timeframe with a minimum of about 6 accruals per month across all sites, with at least 10 to 15 participating sites. Next slide, and my final slide is our update on milestones. We have, in the last year since January, since we have brought this concept to the committee, went through all of the green requirements here. We received our executive committee approval in July. We went through our financial feasibility call. We received NCI DCP approval in September. And we have 2 funding opportunities that we're pursuing now. PCORI had just released a RFP on healthy aging. We submitted a LOI on October 5th, and we're waiting to hear about the results. And then we also plan on an R01 to the NCI next February. Thank you. I'm happy to take any questions.
Wonderful. Thank you, Virginia. Such great progress in the last year and getting this concept ready for submission to PCORI and to NCI. So looking forward to learning more about that. Thank you. Okay, I think if there's questions in the chat, if you can just maybe review those. And now we're going to switch it over to Dr. Barrackos to discuss her concept. Vicki?
Thank you, everyone. Can you hear me?
Yes.
Hello from Canada. On this, my first slide, I will introduce myself that information highly pertinent to cancer cachexia could be extracted from a previously conducted and already published SWOG investigation 0816. In the next slide, I simply wish to reiterate that this is a very poorly understood and extremely incompletely researched topic. It is a devastating wasting syndrome. In the next slide, I try to convey the overall concept. So what we have on the page for the definition of cancer cachexia is that it is a wasting syndrome. You'll find the subject to be musculocentric. Muscle wasting, which can be very profound, is what is understood to drive the morbidity and mortality associated with cachexia. While it is associated with some limitation of food intake, and that also drives catabolism, important piece of this is the catabolic drive emanating from the tumor. And I will elaborate on that in the next slide. So this is a cartoon, and it has for its salient parts, number one, the fact that the tumor and the immune response to the tumor are the primary drivers of cachexia. And that is rolled out through the production of a very large number of molecular entities of different types that provoke catabolic responses in two directions. They act directly on muscle and adipose tissue to cause these tissues to break down. They also act on the central nervous system to invoke further changes, which are endocrine and regulatory in nature, that really push catabolism. So that's the cartoon concept. So in relation to what might have been studied in SWOG 0816, specific catabolic drivers, one, the tumor response. So whether in the course of a study and a treatment plan, the disease was responsive, stable, or progressive. Since many of these actor molecules thought to be involved in cachexia are inflammatory, indices of inflammation are very important and interesting. And because there are endocrine changes and sexual dimorphism, these endocrine changes also could participate in cachexia. In the next slide, I articulate what I just said in the formulation of a hypothesis. So the hypothesis is that progressive loss of skeletal muscle and parenthetically fat mass, aka cachexia, is induced by a variable combination of inflammation, disease progression, and treatment-related toxicity. So the aim is to test the association of muscle loss, which would be the dependent variable in this analysis, with patient parameters, including age, sex hormone status, inflammation, tumor stage, size of measurable disease and response, and treatment toxicity. These are the covariates available from SWOG 0816. Going to the next slide, and Virginia Sun just mentioned this, we have a fabulously precise and specific way to measure this muscle and fat loss that can be enacted very simply by reviewing the images that were acquired to assess tumor response. So this is a depiction of axial lumbar images annotated for abdominal skeletal muscles, visceral and subcutaneous adipose tissue. I would like to emphasize these are available, precise, very specific, and that's what gives you your dependent variable for such an analysis. It is muscle change over time expressed in square centimeters of tissue lost or gained. And this is the kind of distribution that you would typically get in a population of patients on a given treatment plan. So if we go to what will be my next and last slide, when you have a study in a disease site with a specific treatment plan, in which over a period of time, that treatment plan was framed between sets of CT images intended to capture tumor response, it is possible to go in and detect the exact quantitative aspect of muscle loss in each individual patient. using the images already banked or collectivized within the study central site. That measurement is easily accessed, and funding is in place to go ahead and do that. And then this rather diverse level of change can be tested for association in a regression analysis with the covariates I mentioned in my statement of hypothesis. So this would be a fantastic way to try and deconvolute these kinds of catabolic changes according to the tumor, the response to the tumor, the inflammation, and the endocrine status, well adjusted for other important covariates. And I'll finish there. Thank you so much.
Thank you, Vicki. Such an important concept. We look forward to reviewing a large 10-page proposal and hopefully being able to move this forward. So thank you so much for your interest in this topic and being a leader, an international leader in the field of cachexia. So thank you. There might be questions in the chat. We're going to now turn it over to Stephanie Tsai, who is going to present the study on behalf of Allison Grimes as well. Okay, Stephanie?
Hi, can you hear me?
Yes.
Okay. So as you mentioned, I'm presenting a concept on behalf of Dr. Allison Grimes. She's at UT Health San Antonio in cooperation with the Children's Oncology Group. So this is a study looking at the impact of continuous glucose monitoring on glycemic control, particularly on infectious complications in AYA ALL therapy. AYA is adolescent and young adult. Next slide. So why does this matter? So corticosteroids and asparaginase are critical backbone therapies in ALL induction. However, they can cause treatment-related hyperglycemia in up to half of young ALL patients. Excuse me. It's it's most frequent in older children, ages 10 and older, and in the AYA population. The CalGB 10403 induction study described hyperglycemia in 31.1% of the patients. And then in the Alliance induction study, there was an incidence of 22.8% in those ages 16 to 30. Treatment-related hyperglycemia is associated with increased infections, decreased survival, particularly those who require insulin. And at present, there is no standardized approach for detecting, monitoring, or managing therapy-related hyperglycemia. Next slide. So the concept being developed incorporates continuous glucose monitoring. So Dexcom produces one of the leading continuous glucose monitoring devices for young diabetics. It does not require calibration with serum glucose and requires a sensor change only about every 7 to 10 days, which can be done outpatient, so fairly user-friendly. Next slide. So in this concept, the primary aim is to determine if continuous glucose monitoring improves glycemic control in the AYA ALL population as measured by glucose time in range. Secondarily, aim will be to determine if increased time in range correlates with reduction in severe infectious complications such as sepsis and fungemia. So hopefully this will be a NCTN cross-network randomized controlled trial. So the design currently is that everyone will receive a continuous glucose monitoring device, and then they will be randomized to standard of care with blinded continuous glucose monitoring versus unblinded monitoring with management. So they will be monitored for 6 weeks. Target population is those considered to be highest risk for treatment-related hyperglycemia. So it's going to be ages 10 up to 39. So essentially your older kids, AYA population in newly diagnosed ALL. Plan is to enroll them within 4 days of starting induction, which is prior to the day 4 asparaginase administration. Next slide. So at this time, the concept continues to be developed on our every 2-week NCTN calls. We did send out a practitioner survey looking at practice patterns to kind of get a sense of what different cancer centers are doing to determine the best approach to applying continuous glucose monitoring. Gabriel's angel funding was submitted to help pay for the glucose monitors, iPhone sensors, and applicators. And so the next step will be to submit the study concept to the Children's Oncology Group's Scientific Council, which will be this month. So that's kind of where things stand with this.
That's great. Thank you for that update. And any questions, again, feel free to put those in the chat. And then I will just briefly mention the GnRH analog for ovarian protection study in AYA, adults with cancer, which is a study that's going to be originating in SWOG. I think we can go to the next slide. So this study is really looking at investigating the impact of GnRH analogs on ovarian reserve in AYA patients receiving alkylating agent chemotherapy. First aim is to look at ovarian reserve as measured by AMH over a 2-year post-therapy period among those randomized to receive or not receive the GnRH analog. There are some additional aims, which are on the next slide. And those are looking at longitudinal change of AMH and comparing estrogen deprivation symptoms, looking at a high-risk genetic profile for premature menopause and correlating that with outcomes, and also to establish a cohort of female AYA patients treated with alkylating agent chemotherapy with or without GnRH analog to be followed for long-term reproductive health concerns. I think there's a couple more slides, perhaps. And so again, the eligibility on this is going to be anytime after menarche to age 39. Newly diagnosed breast cancer patients will be excluded, given that we already know this is effective in that population. And the patients with radiation to the pelvis or cranial radiation will also be excluded. They are allowed to undergo additional fertility preserving procedures. And the next slide is just about sample size, looking at 250 subjects. We can go to the next slide. And so just the status update, it has been, the concept was approved by COG. So now it's just kind of looking into funding and trying to develop the protocol. Is that it for, Melinda, is that it for all of our concepts? So very briefly in the last couple of minutes, I want to see if there's any updates from some of the committees. And I know I saw Dr. Klemp on the line. Do you have updates from Digital Engagement Committee?
Sorry, I was on mute. Krishna, did you want to add anything on digital engagement? I think that might be helpful for the group. Is she still on there?
She may have had to go to the other meeting. There was an overlap with the.
Oh, that's right. That's right. I think the big things are that, we're constantly looking for opportunities to collaborate with investigators as early as possible. There are a few concepts going through, and I'll see if we can share kind of the notes of those trials. One, obviously, Krishna presented today, which is an overlap. And I think that we're also working on another white paper. So I think the biggest things are just those collaborations early and often, and figuring out how we can really best build a toolkit that will help the investigators. And that's one of the goals for this year is building a useful and kind of needed toolkit.
Great, thank you. Dr. Krause, I see you just tuned in. Do you want to update us on the surgery committee?
I think the biggest announcement from surgery is that their studies are actually allowed to emanate from surgery now. And I think that's created a lot of excitement and new ideas from the different surgeons that participate. And I think related to this committee is some of those ideas would either be better served in this committee or shared. And so I think those are the opportunities we'll look out for from surgery. And I'll sort of, in my role, also hope to shepherd towards the appropriate committee. And I will always, you know, for those that have surgical or surgically related studies or ideas, and the long-term effects, et cetera, please let me know. Or there's a chairman, Dr. Syed Ahmed, who's done a great job in really invigorating that particular committee.
Great, thank you. Dr. Constein, anything from Radiation Committee?
Laura Davis had a comment too in the chat.
Yeah, Lara, do you want to, since Dr. Constein doesn't seem to be answering, Dr. Davis, do you want to share your AYA update?
I would just say I put the information into the chat for both the Early Therapeutics Committee and the AYA Committee.
Okay, so people, the audience can't see the chat. They can only insert, so.
Oh, I sent it to everyone. I thought
Yeah.
that was the case. I'll put it in the Q&A, I guess. But essentially, for early therapeutics, DART is wrapping up, lots of extensive correlates. We have a very active sarcoma working group and a very active CNS working group. So let me know if any interest there. And from the AYA committee, there's a new publication that Dr. Hirschman led with enrollment in NCTN trials for the older end of AYAs, so that's important. And particularly relevant is a task force to define and implement a battery of patient-reported outcome measurements, so PROs for AYAs to be implemented into NCTN trials. Lynn Henry is the SWOG lead on that task force.
Great.
And there she is. She's here, Lynn. I hope it's okay, Lynn, that I shared your email.
Apparently they can see the chat, so good to know. Thank you, Lynn. And then do any of our disease specifics, I know we had a few updates in terms of some of the studies being developed. Do any of our other disease specific liaisons have an update? Great. Okay. Well, then I think we're going to wrap up close to on time, which is a good challenge for us in this committee. Dr. Irwin, any additional comments?
No, this was great. Hopefully, thank you for your participation. I know that we had over 100 participants on the call, and we encourage your concepts, even if it's a one-sentence email to start to Hallie and me, because you have an idea from today or from previous or whenever. We really welcome those concepts and moving them forward. So please reach out to us, and we will see you maybe in November or not, depending on the Thanksgiving break. So we'll share when our next meeting is. Thank you.
Have a great weekend, everybody.
Okay, bye everyone. Great meeting.